Hi, I'm Tom Myers, and I'm pleased to welcome you to the Anatomy Trains Technique series of videotapes. These tapes are designed as a memory aid for any of you who have been in my classes before, and would also be suitable for any manual therapist who wants to add fascial plane release techniques to their structural repertoire. These tapes are specifically designed to give you the feel, the kinesthetic feel of these fascial and myofascial releases, and as such, they come with a few cautions and a few suggestions. The first caution is that these tapes are long on technique, but short on both anatomy and assessment. In terms of the anatomy, we covered this in tape 2 of this series, the Anatomy Trains Overview. It's also covered in my book on the anatomy trains. Well, if you don't have either of those, you can follow along with a good anatomy atlas of your choice. Though we will do a little bit of assessment with each tape, the judgment of when to use each of these techniques is really left to you. You can get more help with the assessment in the Anatomy Trains book, again, or in tapes 3, 4, and 5 of this series, or by attending any of a number of structurally oriented classes, such as those we offer at our Kinesis School. Believe me, I am very aware of the limitations of trying to teach these techniques, which rely on your kinesthesia and your sensitive perception in the body via a medium which is totally visual and auditory. To ease this, we have created a kind of classroom situation in which you'll see me demonstrate the techniques, but you'll also see a student imitating the techniques, and the client comments on how we get there. I think this will make it easier for you to recreate the feeling of these techniques. Though we will be showing you the techniques in some detail, we're not interested in your slavishly imitating them exactly as they are on the video. Call them templates for our techniques. They can be applied in different ways to suit particular clients and particular problems. Once you get the feel of the technique, you can work creatively with it to apply it in many different ways. And we hope that's what you'll do based on what you see here. For ease of learning, we're going to start at one end and work our way up to the other. In practice, this may be the way that you work. It's an okay way to work, but it's certainly not the only way to work by any means. You might start with an area that is particularly held or particularly tight or short, and work out along the line and in both directions from there, and then return to this difficult area toward the end of the session. So what we're going to show is a way, but not the way, of approaching this myofascial meridian. We hope that you enjoy and learn from these videos. Of course, we'd love to see you in a class also, since the learning is often better face-to-face and hand-to-hand. But let's see what we can do with this electronic medium. So the spiral line sweeps down from the skull to the opposite shoulder, around the ribcage and around the belly to the same hip, and down on the iliotibial band and the tibialis anterior to the underside of the foot, holding the arch in a sling, up the outside of the leg, with the peroneals onto the hamstrings, and up the body on the same track as the superficial back line. Okay, with that introduction in mind, let's do a quick review of the anatomy and the body reading, a little bit about the assessment of the spiral line. Both the anatomy is better covered, more thoroughly covered at least, in tape 2 of this series, the Anatomy Trains Overview, and the assessment stuff is covered in much more detail in tapes 3, 4, and 5 of this series. But just a quick review before we go into the technical part. The spiral line, this time we're going to begin up at the head. The spiral line begins with the splenius capitis muscle, which curves down and in from the skull and upper two cervicals across to the sinus processes. And if we keep going in the same direction, we get to the rhomboids on the opposite side. And the rhomboids go out to the scapula, the medial border of it. And if we keep riding on around the rib cage, we ride on the serratus anterior around to the ribs. The external oblique, coming down from the lower part of the serratus anterior, matches up right through the middle of the abdominal fasciae to the internal oblique, which takes us over to the anterior superior spine. The line keeps going down the leg, but I want to make a break here between the upper and the lower part of the line because they frequently work separately. Because this anterior superior spine is what we call in the anatomy trains theory a roundhouse. As you can see here, the muscles are pulling in almost every direction on this anterior spine. So many muscles are competing for this point, so the spiral line is not the only thing by any means working through here. So when we consider body reading in a minute, we'll consider the upper part and then the lower part. So looking at the anatomy of the lower part here, we can see it go down, keep going straight through the ASIS, the spine of the hip. We get on to the tensor fascia lata and the anterior part of the iliotibial tract. I'd like you to notice here that in using the splenius, the rhomboids are also part of another line, the obliques are part of another line. The spiral line is a kind of parasite on all the other lines, and many of the muscles involved in the spiral line are also involved in other lines. So here we see the tensor fascia lata, which we saw as part of the lateral line, also part of the spiral line, but it's the anterior part, the anterior edge really, of this iliotibial tract, which is involved in the spiral line. If we follow that down, we follow that right onto the tibialis anterior muscle. The tibialis anterior muscle, again, part of the superficial front line, carries us down into the inner part of the arch. And lo and behold, we remember coming into the inner part of the arch, the peroneus longus. So we carry around on the stirrup under the foot, up on the peroneus longus, which carries us up to the fibular head. And from the fibular head, we get onto the hamstring muscle. And the hamstring muscle, again, part of the superficial back line now, carries us up to the ischial tuberosity. And from there, we can go right on up, same as we did in the back line, on the sacrotuberous ligament, the erector spinae, and we'll arrive right back up at the head where we started on the erector spinae muscles coming sliding in under the splenius capitis. But again, let's consider, for body reading purposes, just for a moment, let's consider the upper and the lower parts of the spiral line separately. So with that brief review of the anatomy, let's think a little bit about the assessment things. I'm going to limit it this time to the kind of alerts that would alert me to spiral line problems. You can get more information, more detailed information about this from the Anatomy Trains book or from tapes 3, 4, and 5 in the series. But of course the spiral line is involved with mediating rotations in our body, and so rotations are the kinds of things that I tend to look for in the when I'm looking for spiral line problems. But because we like generally, when we're motivating through the world, to have our eyes going in the same direction that our hips are going, rotations in the body don't often show up as rotations. They show up as shifts, because you have one rotation and then you have a counter rotation and you end up with a shift. So these are the kinds of things that I might look for in a body if I was wondering about spiral line. If the head is shifted to one side or the other relative to the rib cage and the pelvis, obviously if it were rotated to one side or the other as well. The other thing that you more frequently see, besides a head shift, would be one shoulder rotated in front of the other. That would be an alert for me that one of the spiral lines is shorter than the other in some part. The rib cage also could be rotated, and the way that we do that is to take a measurement from the lower ribs on one side over to the hip on the other side, and take a similar measurement on the other side. Is one of those measurements shorter than the other? If you look at this fellow here, you can see that his left ribs and his right hip are definitely farther apart from each other. And even though you see those stretch lines, so you might think that that was the short line, the line that's short and the line that would need work, if this character ever showed up in your practice, is the line from the right ribs down to the left hip. So this rotation between the ribs and the hips, the rotation of the shoulder, the shift of the head, and one more, the shift of the rib cage on the pelvis, those would all be things that might alert me to the fact that I need to do some of the work on the spiral line that we'll turn to in just a minute after we do a similar thing with the legs. If we follow the spiral line down here, with this line running down the front of the body and then this line running up the back of the body, we can see that the tissue runs from the front of the hip to the side of the knee to the inside of the ankle. And you can imagine what would happen if these tighten. It would tend to bring the knee inward. So two alerts that tell me that I have spiral line work to do in the lower part of the body. One of them is a medially rotated knee relative to the hip or the ankle, and the other is if the foot is supinated or pronated. Some of you are probably familiar with the idea of the tibialis anterior and the peroneus longus and how they work on pronation and supination. So those are the two alerts that would cause me to think about working with the spiral line in the lower body. So with these in mind, let's go on to the techniques for the spiral line. So the spiral line sweeps down from the skull to the opposite shoulder, around the rib cage and around the belly to the same hip, and down on the iliotibial band and the tibialis anterior to the underside of the foot, holding the arch in a sling, up the outside of the leg with the peroneals onto the hamstrings, and up the body on the same track as the superficial back line. So here we are to begin the techniques, and here with us we have Scott and Monique, who are going to alternate being practitioner and client for these techniques. And if you remember, the spiral line starts, of course it starts in two ways, but the one that I'm going to be working with starts on the left side of Scott's head, comes around his right shoulder and across the external oblique here and internal oblique here. So if you remember when we were talking about the body reading part, we were measuring if these ribs were closer to this hip or these ribs were closer to this hip. In Scott's case, neither one are too much closer, so we're going to do it equally on either side, just to show the technique off. So I'm going to start right close to the ASIS here at the hip bone, and I'm going to turn my fingers back so that when I bring my fingers into his tissue, I am hooking the first layer of the abdominal aponeurosis. And I'm going to bring that layer across. This might feel a little bit burny, Scott, but it should be within your tolerance. Okay. If I lose it and I'm just going over the skin, it will just feel as if I'm skating over the skin, and I can retake another purchase, which I often do over the linea alba, and take off over the other side, and I don't go underneath the ribs, I take myself over the top of the ribs, like that. All right. So if you could give this a try, Monique, going the other direction. So Scott isn't unbalanced from one side to the other. Yeah, so your fingers come back, and then they kind of scoop that tissue up to get a hold of it. And Scott, if any feedback that you can give to make what Monique is doing to be more or less like what I'm doing, what I was doing.
How does that feel?
Pressure feels the same. Yeah.
And you can go either over or you can stop and take it up.
Yeah, it's kind of, with Scott having some hair at the navel, it's usually a little more comfortable to go ahead and take another purchase as you cross the midline.
Okay, I'll go ahead and try.
But with some people, you can just keep right on going through. Yeah, just take another piece, and here's where you're headed. Yeah.
How's that, Scott?
And
That's good.
you'll go just a little bit under the ribs, but essentially you'll be climbing up and over the top of the ribs. Yeah, so you can see that Monique uses another hand to support her first hand there. My hands are 25 years strong here, but if your fingers are not used to this kind of thing, you can use other fingers to help support. And she's carrying it right on onto the ribs. That's great. So that kind of move will serve to lengthen the spiral line all the way from the hip over here to the beginning of the serratus anterior. So our next technique will take up where we left off with the serratus anterior. Okay, so for the next technique on the spiral line, we're going to put Scott on the bench, and I'll demonstrate this and then have Monique try it. You can see in the side shot here how Scott's shoulders are rounding around his rib cage. So we are going to lengthen the serratus anterior by bringing the shoulder blades closer to the spine. If we were looking at a spiral line pattern where one spiral line was shorter than the other, we might be doing this more on one side than the other, but for right now we're going to do it equally on both sides. So I'm going to ask Scott just to take his elbows out away from his body, and I'm going to put my open hand, my open fist, on the outside edge of the lateral border of the scapula, and you can let your arms fall again to relax. And I need to get right up close to Scott. If I try to do this from way back here, I'm going to work really hard with my muscles. And it's not going to be easy for him or easy for me. So I'm going to get right up close where I breathe down his neck, and in that way I can use my chest muscles, and as you can hear from my voice, I can exert quite a bit of pressure, enough to help lengthen this muscle without disturbing my voice and breathing. Now, the motion here is around his ribs. I don't want him to feel like I'm squeezing his rib cage. That's not comfortable, yeah? Okay. So if I'm bringing the tissue around the rib cage like this, and the motion that I'm going to ask for Scott is to bring your chest up. See how I'm coming up to get that lateral border of the scapula? My thumb can be on the scapula, and I'm right up close to him where I can use my chest muscles, and I'm going to ask Scott to just bring his sternum up as he breathes in. Let the back of your neck lengthen, Scott. Yep. And I'm bringing the shoulder blades together. I'm just going to get out of the way a little bit so you can see it, and bringing my hand slightly down once I'm in to help bring him down in the back and up in the front, and to lengthen these serrati. I'll just do this once more. You can let your hands relax, Scott, now that I'm in place. And just let your chest lift. That's it. And I'm bringing my hands together. So, okay. Scott, I'm going to have Monique do this and see if she can get the same kind of feeling.
Yeah.
Okay, Monique, are you ready to give this a try?
I'm ready.
Okay, go.
Okay, Scott, can I have you lift your arms up just a little bit so I can get under and on your scapula? Okay.
Yeah, that's right. Just hook that knuckle kind of under the scapula so that you're making sure to bring the scapula with you.
Got it, and get closer.
Because it's by bringing the scapula medially that you're stretching the serratus anterior.
Okay, ready. You can let your arms relax a little bit now that I'm positioned. Okay.
You want to be close
Straight
enough.
in?
Yeah, you want, well, around his rib cage.
Okay, and then come down a little bit.
As you, once you get in, you can come down a little bit. How's it
Yeah, I
feeling
can
to you,
sense
Scott,
that.
in comparison?
It feels good. The pressure's about right. She's coming in, pressing in more than around than you were.
Okay,
So see if you can kind of go in orbit around his rib cage as you
I understand.
bring it in. That's
How's
it.
that, Scott?
Mm-hmm.
Okay.
Okay. You just need to remember to tell Scott to lift his sternum, because that will really help.
Okay. Scott, could you
Stretch.
please lift your sternum?
Yep. Lift those upper ribs, lift the sternum, breathe into your upper ribs. Any of those things will help make this stretch real. You can breathe out again, though.
It does make a big difference.
You don't want
Keep
to hold
lifting.
this breath. Good.
And how far in do you come? I've got it.
You'll lose juice at some point and start to
Okay.
slide off the tissue. You feel that?
I'm there.
You're there. Okay, then let go. There's no point in carrying on beyond that. Does that feel good?
How was that, Scott?
Okay, now with Monique as client, looking at this area of the rhomboids, the next section of the spiral line here, if one or both of the scapulae are too close to the vertebral borders, where it's not hanging easily and the rhomboids are bunched up and locked short, you can, if you wanted to be one-sided and use your fingertips, work the rhomboids down and out from the vertebral border, starting on that, just right on the edge of the spinous process, and working down and out along the rhomboids toward the vertebral border. This is probably familiar to some of you, and for some people you'll notice that the lower edge of the scapula is farther away from the spine than the upper, so that you may want to work more deeply or more times on the upper part of the rhomboid minor muscle. If you're wanting to work with a little more pressure, a little more power, you can have your client lean forward a bit, and you be strong in your feet, Monique. Yep. And by putting the flat of my elbows, not on, but near the spinous processes, I can work out away from the spine this way to lengthen the rhomboids. If you want to use cross-fiber friction, if that's working better, you can come down this way. But the thing that will work best is to have the client move while you're working. So what motion could I add to this? Monique, let's see, we'll just take one side here so you can see this. If you could reach around, oh, hang on just a second. So I'm going to get situated here. So go ahead and reach around and take hold of the other shoulder. Give yourself a one-armed hug here. So you can see by, yeah, you feel that?
Oh, yeah.
What's the feeling for you?
Just a longer length and a good stretch.
Yep. So as she's getting the stretch, she's actively participating in it. Her movement makes this move. Okay, keep reaching, even though you're not getting very far. That act of reaching keeps the muscle spindles and Golgi tendon, stretch receptors moving, keeps her actively engaged in the motion. All right, well, let's give Scott a chance at this. All right, Scott, have a go with this.
Okay. So we're looking at the rhomboids here, starting at the spinous process.
Mm-hmm. Right about there at the bottom of the cervicals. Yep.
I want to pull your hair there.
So, Monique, you want to feed back to him on what it feels like?
And I feel similar to the work you did. The angle's a little bit sloped down more, but the depth is good.
So the angle of the fibers of the rhomboid are about like that, if you want to try following them.
That feels good. That's good.
You want to try that with both arms? On both, with your arms on both sides?
And that would be with the elbows.
It's more with the flat of the ulna, right? It's not so much the point of the elbow. You get strong in your legs. Okay. Yep.
Bend your head forward.
Okay, so that's going straight down them. That's not quite far. Try going down and out as you go. One of the things we're looking for is not just doing the muscle, but melting the fascia. So it feels a little fast to me, what you're doing. See if you can find the rate at which her tissue is melting. Yeah, that feels more like it. Okay, so then the last thing that you want to add is her motion to this. So do that just a little bit lower than you were before. Yep.
Have her lean forward.
The lower part of the rhomboid. Well, leaning forward is going to move the back muscles, but we'll have her hug herself. Okay? So as you're working out away, you just tell her to reach for her shoulders. You see how that stretches the muscle out from under you?
Yeah.
Yeah, that gives her an active role and increases the ability of the muscles to stretch. Yeah. That's great. If you don't have a bench like this, you can use the side of your table if you can get your table low enough so that they can sit with their feet on the floor. You do not want to do this on the side of the table with the feet off the floor. That is not a good idea. Feet need to be on the ground. Okay, so turning our attention to the lower part of the spiral line, with Monique as a client here, I'm going to set her up with some support for her knee and bend the other lower leg so that the leg is well supported. If you remember, the spiral line coming across from the belly here comes over the ASIS and onto the anterior edge of the iliotibial tract. So if we're going to work that anterior edge, we could work it in two ways. We could work it with the forearm, and I'm going to place one part of my forearm against the top of the tensor fascia lata at the ASIS, and the other one just above the greater trochanter. And by just leaning into my hands, I'm going to bring them apart. But you know what? I'm skating over the surface, so I'm going to add lotion, not oil, to what I'm doing. And in this dry time of the year, just to make sure that I am moving with tissue, not just skating over the surface of the skin. So now I'm going to go down that anterior edge of the iliotibial tract. The way that I can ensure being on the anterior edge is to let my forearm drop a little. So, like the string like the bow of a violin, getting that top string by letting my forearm drop, I'm getting the anterior edge of this iliotibial tract when I want to have my attention specifically on that. How's this doing for you, Monique? All
Yeah,
right?
it feels much different with the lotion. That feels fine.
Yeah, I wasn't getting in there without the lotion.
Made a big difference.
Yeah. Okay, and I can carry that right down to the condyle of the knee, and you'll feel me come up against that station, that attachment there, and that's about as far as I want to go. Okay, so let's give Scott a chance with this on Monique. So come ahead in and locate your forearms, one just under this one, the left one.
Right, that's the line that comes
Yeah,
down.
that's the line that comes down there. And, okay, yeah, you can do it that way. Great. So, Monique, you can let him know how it's doing. Again, Scott, you know what? I'm gonna deepen you and slow you down.
Mm-hmm.
So you really let your weight go in there. Is that okay?
That's good.
And then by bringing your shoulders this way, bring your whole weight towards me. So you just lean into that arm and let it melt down through this tissue. Yeah, even slower. Even slower. Okay, and if you just drop your wrist, you'll get more onto the anterior part. There you go. This would be especially in people who have an anterior tilt of the pelvis, where you want to get that anterior angle, or in the connection described in the book, or tape 3 of this series, where we talk about the connection between this anterior part of the iliotibial tract and the medial arch. How's that doing? You got it?
Ooh, yeah.
Are you awake?
You got him.
Okay, that's good then.
Yeah, that was good.
So the other part of the lower spiral line coming back up the body is this outer hamstring. And one way to reach toward that outer hamstring is to set Scott so that his knee is well supported by a pillow. The upper leg supported by a pillow this way, and you can see very clearly this is the iliotibial tract, and here is the biceps femoris. So to get with the fascia of the biceps femoris, we can come in on the top of that muscle and bring that tissue down toward the knee. So if I want Scott to be moving in this, I can get him to lengthen the foot down off the table, and that will stretch that muscle. Good. Come on back. The other piece of the biceps femoris here is the short head of the biceps femoris. And is that too much right in there?
The sore spot, yeah.
Yeah, that piece is sore right in there. That's the short head of the biceps. So is it okay?
That's okay.
Going in there? All right. And again, I'll stay where I am, and you can control the stretch by taking your foot off the end. Feel that muscle stretching out from under? You're doing the stretch now by straightening the knee. Yep. So that's the short head of the biceps. Good. Come on back up. Okay, Monique, give this a try with the hamstring.
Okay.
Yeah, about a third of the way down is where you can pick up that hamstring. That's great. In there.
How does that feel, Scott?
Good. Probably use more pressure.
Tell you what, when you're working on the leg like this, you might want to try using a little bit of lotion. Yeah, using oil during these techniques will really make it hard on the person, because if you oil up the skin, then you're going to have to press that fascia down against the underlying bone. But if you just use a small amount of lotion, then you can go over the skin, go down to the level of fascia that you want to contact, and work with that layer without having to push all the layers against the bone. So
Feel better?
Yeah, there's not nearly as much hair pull.
that's the right thing to say. Okay, good. Now that looks
Yeah,
good.
it's tight.
Now, what could he do to add some motion to what's going on?
Okay. Could you slowly take your leg off the table and extend it down?
Great. Okay, that's
Okay,
good.
bring that back.
And I just wanted to locate you also for this. If you feel the tendon of the biceps, you can get the short head of the biceps essentially behind the tendon. It's not an
Is that
area
it?
he wants you to be, but it's an area he
No,
could
no.
use. He could use a little
You
work.
need to be there.
Okay,
Yeah,
is that okay?
okay.
Yeah.
Does that feel
Yeah.
same?
Yeah, try
And I'll have you
hooking.
take.
Yep, try hooking a little bit more around the tendon,
Okay.
like that. There you go. And then in towards the femur from there, and that's where that short head is. That's great.
Okay.
Okay.
You want to extend your leg off the table? Can you do that one more time?
Is she getting in there?
Yeah, a little bit deeper.
A little bit deeper?
Yeah.
Yeah, flipped in. Okay.
Okay.
Let's
You
see.
can reinforce that hand with the other hand if you want to put one hand on top of the other.
How's that?
Yeah. that's
Okay.
in there.
Yeah. Got
Yeah,
it.
now
Okay, and
he
extend
does.
the leg.
You don't have to do that much. You're pinning and he's stretching by extending the knee. Yeah, that looks like it.
How's that feel?
Yeah.
Okay.
Okay, good. So the lower part of the spiral line here includes coming down from these two things that we were just working in the thigh. The anterior part of the ITT continues onto the tibialis anterior. The lateral hamstring continues onto the peroneus longus, and as many of you will be familiar, those two muscles form a sling under the foot and under the arches. So if we look at the foot and the foot is supinated, we can see the reciprocal relationship between these two is that the tibialis anterior is probably locked too short and too tight and lifted, and the peroneus longus too locked long and extended out here. So that we would want to, in the case of a supinated foot, bring the tibialis anterior down and the peroneus longus up. The opposite would apply in the case of an everted or pronated foot, where the tibialis anterior would be locked long and not sufficiently lifted, and the peroneus is probably too tight and pulled up. So I might want to work up on the tibialis anterior, I might want to work down on the tibialis anterior fascia, depending on what I was finding. Is that a bruise? Is that okay?
Yes, it is. I did not have it.
Okay, it's not sore?
Nope.
Okay. So, working down on the tibialis anterior, I'm going to take my whole finger and from knuckle to fingertip and lay it along the edge of the tibial bone. So I'm going right along the tibialis anterior. I'm going to make sure that her leg is lying straight. And then I'm going to, as I come down the muscle, taking the fascia and the muscle toward the arch, I'm going to have Monique dorsiflex and plantar flex to create motion in the tissues, which is going to help me locate myself and help her participate and help her nervous system participate in this opening. And again, I might need to do that several times. The tibialis anterior is a much deeper muscle than we often give it credit for. The muscle itself, of course, is on the surface, but I mean that it extends down into the calf quite far. So sometimes several to many applications of this kind of work is necessary to open the muscle all the way down to its deeper parts near the interosseous membrane. If I were working up I do not want to press on the tibial bone, so I will lay a set of knuckles along the edge of the bone where I'm just off the bone, and again, having her dorsiflex and plantar flex, if it were that I wanted to lift the tibialis anterior and carry the fascia headward away from the arch, then I could be working in this manner. To work the peroneals, I often work with the thumb on one side of the leg and the fingers on the other, so that is handwork. And this does require some strength in the fingers. If I wanted to work the peroneals toward the head, I can be working this way, and what's going to make it more effective? Her movement. So dorsiflex and plantar flex. Good. Good, good. And keep that going all the way up to the fibular head. And conversely, I could be working down from the fibular head, again with my thumb on the other side, putting my 3 fingertips in a row, bringing that tissue right under the fibular head, down. If you're working way back here on this bulge, you're probably working on the soleus. The peroneus are these tiny sets of muscles here that come down directly under the fibular head, and they're going to end in tendons right down here at the ankle. The muscle comes down almost to the ankle, so it's worth working almost to the fibular malleolus there, but probably not beyond it, because in my world it's difficult to stretch tendons. They don't give way much. Now, the last piece here in terms of this, which is not strictly part of the spiral line, but given that we're thinking about this arch-like arrangement under the foot, if we think of it in terms of fascial planes, in a supinated foot, the fascial plane on the outside of the leg, what we've been calling the lateral line, but also part of this spiral line, has dropped, and the part on the inside of the leg, which we're going to deal with later in these tapes, the deep front line, has lifted up. So to change the fascial plane in a supinated foot, we could work not with particular muscles, but with the whole fascial planes of the inside and the outside of the leg. So to do that, I'm going to put a large flat surface of this first phalange against the inner and outer part of the leg. And presuming, again, that I'm working on a supinated foot, I'm going to lift the outside and drop the inside. I'm going to have my hands opposing each other. So I'm going to start just a little higher on the inside, a little lower on the outside, and I'm going to have you dorsiflex and plantar flex, Monique. Yep, up and down, that's good. As I lift the outside and lower the inside, and then I'll bring the other hand up and continue my trip up with the outer hand so that my hands are opposing each other across her leg. And you'll notice that I'm getting my face pretty close to my work. That allows me to keep my elbows wide, keep my elbows dropped, so that my hands are opposed to each other. If I get way up here and I try to do this just with my arm muscles, I'm going to be working really hard and I will not be sensitive to her. So I need to get pretty close to her to do this fascial plane work. Is that comfortable for you?
Comfortable.
Yeah, that's good. Obviously, if she had an everted or a pronated foot, I don't like the word pronation, but it's commonly used, you can see that the tissue on the outside of the leg would be pulled up, that of the inside of the leg would be pulled down. So, okay, you can relax now. If that were the case, which it isn't in Monique's leg, but we could bring the outside down and the inside up in an absolutely similar way. So the way in which you apply this technique will depend on what's going on with the support in your client's leg. Again, you want to look at this, as with the back, you want to look at this when the client is standing and believe what you saw when they are standing. Most clients, when they lie down, through the action of the soleus, will have an inverted foot, but that's not necessarily what it looks like when they're standing up. When you're doing this kind of assessment, you want to do it on the basis of what you saw when they were standing. Okay, Scott, so would you like to give these a try?
Yeah. Now, when you were demonstrating this first one, and you were coming down
Mm-hmm.
with your, using your
Yeah.
knuckle, and you were pressing down and pulling inward. From a practitioner point of view, that looked awkward to me. Is there any reason why you wouldn't stand over here and and push with the body and push downward?
Okay. We can try that, but actually, let me bring this one in for you.
Mm-hmm.
If you get your shoulder, if you have a way of getting your shoulder past your hand,
Mm-hmm.
in other words, take a step back with this foot and lean way forward,
Mm-hmm.
then you're actually pushing with your body.
Okay.
Do you feel that?
Mm-hmm. Yep.
So if my shoulder's back here and I'm pulling with my hand, it really is awkward. But if you get your shoulder past your hand, it's more of a leaning.
Okay. And the pressure is in the knuckle? Is it on the
It's
flat?
it's on the flat. Yes,
Mhm.
it's primarily on the flat of that first. Okay, and she gets to move.
And she gets it right.
Yeah, and
dorsiflex.
the idea is the finger is sort of guiding along the bone.
Mhm.
There? Yeah. So you're. And you're getting a little bit of work done with that second knuckle too, aren't you?
Yeah, I'm sort of.
Yep.
Is that
That's great.
okay?
But that's great. That's great what you're doing. But take your own suggestion. Come on around here and try it facing into the leg.
Well, then I would be using a different. Well, yeah.
Yeah. No. Don't use the same thing. Use what you would use. Use your fingers.
I
use
would
your
probably use my thumb.
thumb. Okay, so use your thumb.
Um,
Okay, so, but now you have to say, how does that feel, Monique? Oh, I don't know. We're getting a.
Feels more, I guess, precise, but not as, the width isn't as great, but I felt when you were coming from below the feet and pulling
so
down,
instead of using the two fingers.
I think the knuckles got a little bit more consistent depth
Mm-hmm.
Okay.
with the movement.
Yep.
So, whenever you get any of these techniques from these tapes, it's really important that you adapt them to your own way of working and your own hands and, of course, to your clients. But we're not interested that you imitate these techniques exactly as they are. If you get the intent, you can alter your own body position or your hand position to achieve the intent. So, the kinds of changes that he was making, that's great. If it works, it works. Okay, Scott, give this piece where you're taking the fascial planes on either side of the leg a try. Yeah. Okay. Right, so the little finger of this hand and the index finger of this hand start about at the same level, and then you're going to move that way. And I want to make sure that her leg is really knee facing straight up towards the ceiling. Yep. Okay. All right, I think that's the idea with your hands. How's that feel?
That felt good.
It felt good? Okay. So I just want you to add her movement into the mix. So get yourself situated. First go in before you start to move. And then as you start to move, get her to move.
Okay, now dorsiflex and plantar flex.
Yeah, that's it. And then she needs to relax in between your, when you get situated again,
Mm-hmm.
you tell her to relax, and then you come in, and then you start to move. Which way are we going? This way. And you get her to move again. There you go. Okay. So if she keeps moving, it's really hard for you to get in on the tissue where you want to be.
Mm-hmm. Okay, dorsiflex and plantar flex.
So you, who are long of limb, can do that in a bench. By the time I get there, I have to get out of the bench. 'Cause
And doing the upper part, even for me, this is feeling like I can't get.
it's a bit of a reach. Yeah.
Right.
So if you stand up and get in there, yeah, that's it. Okay, the only other thing I'm going to do is soften your fingers. Yep. So it's really that surface that's opposing each other.
Mm-hmm.
Okay? Try that.
Plantar flex and dorsiflex.
Is that all right with your hands?
Mm-hmm.
Or is that too much?
No?
Uh-huh. Looks good to me.
Okay.
Yeah, that was good standing up. I noticed it. So,
A difference.
and there was
Yeah,
the pressure
you
was
can get
deeper.
my elbows down more.
You were right there.
Yeah.
So that's the, actually we're going to do one more technique on the bench, and then we'll proceed to the balancing work at the end of the session. Okay, so one last technique that we can use here is a standing technique. So I have Monique standing in front of the bench, or any stool will do, and I'm going to place my feet, my toes, my big toes, right in the front of her ankle to stabilize her feet. And then I'm going to ask her to bring both knees forward. And as she brings both knees forward and back, I'm going to watch the tracking of her legs. Oh, you know what? Her feet aren't parallel, so I'm going to ask you to bring that heel out, this heel out just a little bit. Good. So the feet are parallel through the second toe. When the second toes are parallel, now I'm going to ask her to, I'm going to stabilize her feet with my feet and ask her to bring the knees forward. And I'm seeing whether those knees are tracking straight forward over the second toe or not. And if not, I'm just going to help them do that. One of the things is that I want to make sure that she is not sticking her rear end back as she goes forward with her knees. So take your knees forward. If you go into an anterior, if your client goes into an anterior tilt like that, that's not what you want. They tuck their tail under a little bit as the knees come forward. That's it. Okay. Now, what am I going to do? I'm going to put my thumbs above the kneecap in the front, and I'm going to reach around and back and take a hold of the hamstring tendons with my fingers. My fingers are not joining in back. They're just taking hold of the hamstring tendons, and I've got one thumb on top of the other in the front. And now I'm going to ask Monique to come forward, and I track it right out over the second toe, and I keep that tracking. It's more important on the way back than it is on the way down. I keep that tracking going on the way back. Track it forward on the way down, track it back on the way back. And I have her come not quite to fully extended with her knees until the last one, then I bring her fully onto her foot, fully into extension. Obviously, I would do the same thing with the other knee on the other side. Okay, Scott, why don't you give this a try?
Okay. First question is, why did you have your feet on top of hers?
Okay, so that when she brings her knees forward, she doesn't go into pronation or supination. So you put your toes right in, there's a little hollow right in front of the foot, and you put your big toes on that, and so you're securing her feet on the floor, and you're making sure first that they're parallel, which we already did with her.
Okay,
Excuse
now-
me, but you want to have the feet parallel.
Okay. Am I sitting too close to her? I mean, I have longer legs with
Yeah,
my
so
knees.
just slide back on the bench a little bit, I think, because her knees have to have room to come forward, or you can just let your knees go out a little bit.
Okay.
But in any case, now just watch her knees come forward while you make sure she's not tucking her rear end back. Yeah, and you watch that track. Now, do you see how that left knee is coming in a bit as
Yeah.
it comes forward? Okay, so your job as you put your hands on her leg with the thumbs above the kneecap, sort of one on top of the other, and the fingers around so you're grasping the hamstring tendons. Okay, and as she comes forward, you resist that tendency to go in and track her right over her second toe so she doesn't bend in with that, she doesn't rotate in with that knee. However, yeah, it's the going back where the work really happens.
Yeah.
Really grab a hold of that and make it go, well, we don't say things like make it go straight back, but allow it to go straight back. Encourage it to go straight back.
And Tom, were you working more in the back around the hamstrings, kind of wrapping your hands around
Yes,
a little bit?
well,
Okay,
is that what it feels
a little
different?
bit different. Scott's more medial,
Uh-huh.
and I sense that you are more lateral and kind of wrapping around.
Okay, so see if you can hook the
Yeah.
hamstring tendons.
Yeah.
It's a bit of a gripping.
And that's where you really feel the pressure.
Yeah, the
not so
work
much in
the
front.
work is, well, it's all around the knee, but the work is in the difference of the hamstrings. As she comes forward, those medial hamstrings are pulling that knee in, so you're having to lengthen those medial hamstrings as she comes. The tissue around those medial hamstrings, to be more precise. Okay?
Yeah.
Yeah. Okay, so my only advice would be a little slower on the way back. So the tissue has time to adapt and change to what you're doing. Yep.
Big difference.
Good. All right. let's watch Scott doing this forward bend. Scott, I'm going to ask you to put your feet a little farther away from you than you would normally do. Yep, and then together with each other. Yep, and your knees together. And put your hands outside. And just bring yourself up tall. And let your chin drop towards your chest and begin to keep on going. Just go on forward and let your arms hang. Let your arms hang off the, that's it. And just watch him go forward vertebra by vertebra as he leans forward, and just let yourself go right over the tops of your knees as if you were going to put your head on your feet. And just go as far as it's comfortable for you to go. Okay, and then bring yourself back up by dropping your tailbone and your sacrum and stacking up your lumbars and stacking up the thoracics and the thoracics and the thoracics. Okay, now when you get to here, whoa, let your head fall just again. Use your sternum to bring your head up onto your body. So you lift your head up onto your body with your breastbone. That's it. Okay. And just now do it quite quickly going forward. Same kind of thing. Drop your chin and let your back go forward. Great. And come up from the bottom. Stacking it up, stacking it up, stacking it up, and put your head on. Great. Then I'm just going to go down your back like this. Okay, so as we go down Scott's back, and again, you're going to let your head fall forward, Scott. Great. We notice that his back tends towards an exaggerated forward curve in the thoracic spine. It's not bad enough to be called a kyphosis, but it's tending that way, so we want to bring the tissue down and together as he goes forward in this section of the spine. You be strong in your feet, Scott. Yep, that's right. Resist with your feet as you slowly let yourself go forward. Down here, he tends to be a little narrower in the back, so I'm going to just widen that slightly because it was a bit of a valley when he was sitting up. So we're going to dig out the valleys as we were. I know it looks like a mountain now, but when he was sitting up, it was more of a valley. So come on back up again. Great. So now we're rolling into the end of this spiral line session with the proviso that all these techniques need to be adapted to your particular style of working and obviously the pattern of your individual client. So we hope you'll use these techniques with creativity and ethically and responsibly. As usual, and as in the other tapes, we want to end by bringing our work with this line into integration with the neck and the lower back. And I remind you that the splenius is part of this line, so that we might, if we had any head shift or rotation, want to pay particular attention to the splenius on one side or the other. And that there are two ways of getting that. One is to support the head a little bit away from the side that you want to work on, and using the mastoid process and being careful of hair, pulling, bringing your hand down and around the neck and in. Is that okay with the pressure?
Yes, that's fine.
Yeah. So you're taking this tissue and lengthening it, and that would be on the side to which the head was rotated if there was a rotation, or on the opposite side of a shift if there was a head shift. And that follows right around the neck onto the back where the splenius attaches. Of course, once you cross here, you're working through the edge of the trapezius, but the trapezius on all but the very buff is a very thin muscle and easy to work through. The other way that we've talked about of getting the splenius is to reach under the neck, supporting it with the same hand and bringing the attachment of the splenius toward the the upper part of it, where it comes onto the occiput toward the midline. Okay. And as with our other tapes, this endgame work with the neck can include work up the laminar groove on either side, where we reach under the neck and bring the fingertips up the laminar groove in between the spinous processes and the transverse process to lengthen the neck, or work underneath the occiput to loosen the suboccipital area, and any other loosening that you might want to do to ease the rotation of the neck, which we don't need to do in Monique's case because it's rotating very well. And if you could bring your chin in, Monique, and slide your head up towards me. Yeah, there's still just a little resistance to having that neck come down. You can relax now. So again, I might want to do just a little more loosening of these muscles on the back of the neck so that her neck could rest more easily down. When you feel that you have eased the neck, there are two other things that we're going to include in the end game for this session. One really nice end move that we haven't done up till now, but we'll show it now, is to, it's a bit like the pelvic lift that we've been doing at the end of each session, but we do it between the medial border of the shoulder blade and the back. Scott, if I could get you to roll over this way so that my hand is placed, a little uncomfortably right now, under his body, so that my three fingertips are between the medial border of the scapula and the spinous processes. I am not on those, I am between them. Okay, go ahead and roll back. And with my hand in place here, and the other hand holding the shoulder down, I bring the tissue down between the shoulder blade, pulling straight toward his tailbone, not down and out. This has a really nice feeling of resetting the shoulder, yes?
Yes, it does.
Can perhaps feel the difference between the two shoulders, and you don't have to turn, I can get there this time. And just holding the shoulder a little bit back so it doesn't creep forward, bringing the tissue down between the shoulder blades. Like that. And as usual, when we finish, we're also going to want to melt what we've done with the spiral line into the lower back. So with Scott, we will have him bring his knees up. And with his heels fairly close to him. And then if you could just slowly curl your tailbone under and begin to lift your pelvis off the table, that's great. And I'm going to bring my hand under his pelvis and under his lumbars, and now you can let your weight come back down onto my hand. Just fully relax so that I have your full weight. That's great. And then I hook my fingers, and I'll show you where my hand is. Just roll to your side if you would, Scott. You can see my hand so that my fingers are divided across his spinous processes, and there I can get a hold of the thoracicolumbar fascia on both sides, and with my fingers hooked, bring it straight down towards his heel. And as we've said on the other tapes, in case you're watching this tape first, you need to bring that hand straight towards his heel, not towards your shoulder, which would be the tendency. So again, just bring your heels a little bit closer to yourself. Come on up. And I would often do this 2 or even 3 times at the end of a session as necessary. And it has a calming effect on the system. And generally speaking, people will go, ooh and ah.
Ooh and ah.
Good.
Yes. It does feel really good.
Okay, good. And if I wanted you to do this, I'll get your feet off one or the other. If I wanted you to do this as a homework piece, I could have you step down on your feet, lift that up. Now, without my hand there, drop this vertebra. And then, okay, don't work too hard now. Have it be a relaxation. Yeah, there. Dropping that one, and that one, and that one, and that one, and then your sacrum, and then your tailbone. Okay? All right, well, that's a summary of approaches to the generalized approach to the spiral line. Of course, you'll need to adapt these techniques and approaches to your own clients and to your own style. And we hope that you will use these responsibly and ethically, and that you've learned something. Thanks for listening.